Well, thanks everybody for coming out today. I hope to educate you all on this new great innovation we now have here at Bone & Joint for doing hip replacement surgery. Some of you I know came for the education, but a lot of you may have just came for the good food. So I hope that it was as good as well. Well, obviously today we're going to be talking about hip arthritis and the treatment of hip arthritis. And before we can really get into the nuts and bolts of why I like the robotic assisted hip replacement application, I think it's important for us to understand what hip arthritis really is, what a normal hip is. And part of this educational seminar is just to educate patients about some of the treatment options that we have for hip arthritis. I want to talk about hip replacement in general. There are often some misconceptions about what actually happens during a hip replacement. And then we'll talk about the use of the Mako robotics in hip replacement. And then we'll open it up to question and answers, and hopefully you guys will leave here full and well educated. So first of all, the hip. I mean, everybody talks about the hip being, a ball and socket, because it is. It's essentially the connection between your pelvis and your legs, and it's a round socket, but a lot of things in the hip are necessary in order to keep it in. So everyone realizes this. If you've ever eaten a piece of chicken, that the joints just aren't floating around. There are a lot of things that help keep it in place, specifically the ligaments around the hip joint and the capsule. The bone surface of the hip is covered by cartilage, but also around the hip there's something called the synovial membrane, and this membrane is very important for lubricating the hip so your hip stays nice and healthy. Between the cartilage on your hip, the synovial membrane, the synovial fluid, the ligaments and tendons, all those things are necessary for you to be able to have a pain-free working hip. The kind of hips we're talking about are ones that aren't so normal, specifically arthritic hips. 46 million Americans have doctor-diagnosed arthritis. Now, that's of those, over 812,000 are Oklahomans. There are over 100 different types of arthritis. The most common type is osteoarthritis, which is basically wear and tear arthritis. The exact causes of arthritis are unknown. Some people are obviously more prone than others. There has been research showing that there is a role of genetics in 40 to 65% of patients with hip arthritis. There are other kinds of arthritis: rheumatoid arthritis or inflammatory arthritis, arthritis from injury, arthritis from losing blood supply, arthritis from having an infection, and then people often talk about fibromyalgia, other types of things that cause hip pain. Arthritis or rheumatism is the leading cause of disability in the United States. So I bring all these things up just to educate you all on the fact that this is a very common problem, and obviously you all are here because you either have this disease or you know someone that does. The other thing to keep in mind is we are in an election year, and I know this is, what's going on in healthcare right now is pretty much in the forefront. The social impact of arthritis in America is definitely rising. Baby boomers include 78 million Americans, which is about 26% of our population. Baby boomers are basically going to drive an increased demand for total joint arthroplasty, and they're also going to drive patient expectation to be more active and have longer lasting components. Not only that, but younger patients are getting more and more arthritis from being more active, and they want better procedures, better implants, so that they can return to work and activity. So when patients come to see me, the things that I'm asking about hip pain, or what's their main problem. Usually it's pain located in the groin region is where hip arthritis is, and we'll talk about some other signs or symptoms for hip arthritis. People often limp. People have pain when they bear weight. People talk about their hip being stiff. It's interesting, a lot of young males come in and one of the things they first start complaining is they can't put their socks and shoes on. And it may not be that painful, but they are really stiff. And as the disease worsens, Patients may even become awakened at night because of the inflammation that they're having in their joint. Things that we see on exam, once again, the gait pattern changes. People limp because of their arthritis. We start seeing muscle atrophy, the old use it or lose it. You start favoring one side, the other side takes over, and the side that you're favoring loses muscle strength. Once again, the range of motion is decreased. And on X-ray and MRI, we see obvious signs of arthritic changes. I mean, people often talk about, my hip's bone on bone. Well, that's just a sign that the cartilage in your hip has been fully destroyed by your activity. The other thing I want to educate you all on is other things that can cause hip pain. And I really think about the hip as being three different things. People often come into the clinic saying, my hip hurts, which is usually your hip joint. They'll say my hip hurts, which can be your hip joint, but more often it's a muscular problem, such as trochanteric bursitis or tendonitis, where the muscles attach on your greater trochanter, which is this large bone on the outside of your hip. Problems with pain in your back, being referred to your hip, and that's usually my hip hurts. So when we have to really think about these things when patients come in, and as you as a patient have to make sure your doctor is being thorough in ruling out other causes of hip pain that could be causing you to have the discomfort. When we treat hip pain, we have three goals. This is whether we do surgery or not. Number one, we want to control the pain. Pretty simple. You hurt, we want to fix it. Number two, we want to improve your function. So by improving your pain, we hope that we can allow you to be more mobile, you'll be able to do the things that you enjoy. And finally, in the treatment of osteoarthritis, we want to educate patients and family about the disease and what the treatment options really are. And that's part of why we do seminars like these, so we can understand what our options are. Non-operative treatments are pretty straightforward. Activity modifications, if it hurts, don't do it, which to some degree can be helpful, but when you get to the point where your quality of life decreases because of it, it's not that helpful. Number two, anti-inflammatory medications. Ibuprofen, naproxen, aspirin, Motrin, things that you can take over the counter and things you can take by prescription. Anti-inflammatory medications are very effective at controlling hip pain in the earlier stages of arthritis, but it often becomes less effective in the later stages. Steroids, which can also be given orally or in the form of injections into the hip joint. I know a lot of you know about injections in the knee joint, which are fairly effective and can be done over a period of a long time. Hip joint injections are a little less predictable in how effective they can be, but we still try them in patients that are trying to do everything they can to avoid hip replacement. Ice and heat, bracing, not a whole lot of bracing that can be done with hip arthritis to decrease pain, because it just makes you stiffer than you were before. Physical therapy can be helpful just to keep the motion going. One of the things I often say is motion is lotion, so if you can keep your hip moving, then a lot of the secondary effects from the inflammation can be decreased. Well, here's the reason we're all here today, talking more about the surgical options of hip replacement. And hip replacement, there are things that can be done for hip arthritis short of hip replacement, but most of them are transient treatments trying to buy more time once again. So you often hear about total hip replacements, which is what we'll talk about today mostly. Surface replacement, where we cap the end of the thigh bone instead of cutting the end off and putting a stem down. Partial replacements, which we usually only do in cases of hip fracture. You all may know someone who broke their hip, or you may have broken your hip. A lot of times they'll get what's called a bipolar hip replacement, where instead of replacing the ball and the socket, you just replace the ball. And then hip fusion, where you make the hip connected to the pelvis, which really is very rarely, if ever, done in the United States any longer. So the goals of hip arthroplasty, once again, decrease pain, achieve a reliable, reproducible, and durable functional outcome. So we want a hip that doesn't hurt and a hip that allows patients to do as much activity as they can tolerate. at the same time not do too much to put too much stress on the implant. And so how do we achieve this? Well, implant selection is important. We'll talk a little bit about this, but surgical technique in hip replacement is probably the most critical thing in achieving a durable, long-lasting hip that's going to give you reliable and pain-free results. So total hip arthroplasty, it's the fancy word arthroplasty for replacement. Arthro means joint, plasty means replace, so we're replacing the hip joint. When we consider operative intervention is when we fail the conservative measures. We've tried everything short of surgery. When we start having effects on our quality of life, activities and sleep. We start having pain in other joints from compensation, so you're limping, your back starts hurting, your knees start hurting, loss of function, and then when you sit down and talk to your doctor and you guys realize that that's really the only option for you if you really want to do the things that you want to do. So what this model, what this diagram depicts is what we actually do in hip replacement. We remove the damaged parts and we replace them with a metal cup, sometimes a plastic liner, sometimes a metal ball, and a stem that goes down the thigh bone. And during the surgery we do things to allow us to know where to put those. So I'm kind of go step by step what we do in general during a hip replacement. So we remove the femoral head, or the arthritic surface of the femur, and we do that after we take it out of the joint. So during surgery, with a patient lying on their side like this, we basically have to pop your hip out of your joint, and then we remove that arthritic part of the thigh bone. Once we do that, we prepare the acetabulum, or the cup, or the hip socket. And we do that basically with a round cheese grater that basically creates a round socket for us to put the prosthesis. So if you look here, it's a reaming tool. We basically go up, start small, and go up to the size that we need in order to fit the prosthesis that is matched to that patient's size. And then once we do that, we put the acetabular component, or the metal cup, into the hip socket. And the hip sockets that we use today are what are called press fit. Used to, and sometimes still, the cup was cemented into the hip socket. Now, routinely, we actually do what's called a press fit technique, where the cup is actually pressed into the bone and the bone grows into the cup. So the fixation is achieved by what we call osteointegration, or integration of the bone into the metal cup. And then on the femur, or the thigh bone, we have to prepare that to be able to put a stem down the thigh bone in a metal head. And we do that with special instruments that rasp or ream out a geometrical shape to fit that particular prosthesis. And then once we do that, we have a trial component, which is comes in the set, that we trial and see which one fits best for that particular patient. Then we put in the femoral stem, which is also, just like the acetabulum, is press fit into the stem. Some surgeons still do cementing techniques to cement the stem in. Once again, no longer the gold standard for hip replacement. And then once we do that, we attach the femoral head, which come in different lengths depending on where we're trying to get your hip in space. And so a completed hip replacement basically is, just as it says, a replacement of your hip. Socket, stem, ball, and a plastic liner. So instead of having that grinding osteoarthritic pain, now you have a pain-free, well-functioning, moving hip. A lot of people ask me about bearing surfaces in hip replacement, and this is something I wanted to touch on briefly here today, because I feel like it's something that patients need to understand pros and cons for each of them. The gold standard, if you will, for hip replacement is a metal ball and a plastic liner, specifically a highly cross-linked polyethylene liner. And the reason it's the gold standard is because we have a lot of good studies that says it is. And sometimes that happens because there aren't enough older studies, hasn't been enough time with newer technology to show that it's as effective. But we can expect that at 10 years, 90 to 95% of patients will have their same hip joint. And at 15 years, 80 to 85%. And it goes down about 1% per year after that. And what wears out is the plastic liner. Just like your hip socket wears out, the bearing surface wears out, the tires on your car wear out, the O-rings in your engine wear out. There's always something that's going to wear out, and that's the rate limiting factor. So there are different options. You know, we have metal on metal. This has been in the news a lot lately because of some of the hip recalls. Not all metal is the same. Metal on metal is a very good alternative for some patients. It offers the biggest advantage is it offers a larger ball, which allows the ball to decrease your chance of dislocation. So a lot of surgeons will use it as a, for lack of a better word, a bailout, because they may not be able to get the parts in as perfect position as they would like, even though they're trying to do it. So it helps them, in a way, cheat, so you don't have to maybe do that. But you do jeopardize, or you do influence some functional outcome that way. There's also ceramic on ceramic, and we're now doing a lot of these what are called dual mobility heads, where you have a metal cup, a big polyethylene ball, and inside that either a ceramic or a metal ball. So every bearing option works well for patients. They all have their pros and their cons. It's something to discuss with your surgeon about what they think is best for you. So the big question we have to ask ourselves, we've got great technology with implants. We've been doing hip replacements for dozens of years. How do we make it last as long as possible? And that's the real question. There are obvious patient factors we can't control a lot of times, but we can try to educate patients to make it last. There is the implant, and I think implants today are very, very good. They're not perfect, but they are very, very good, and they do last a long time if put in properly. And then there comes the surgeon, and that's where our big robot friend comes into place. And the reason why is the surgeon with the help of robotics. So I've talked to you a lot already about what a hip replacement is. What makes this different? What makes this MAKOplasty robotic arm interactive orthopedic system a more valuable tool for surgeons in putting in these prostheses? Well, there's a lot of things, and we'll go over each of them. The first one is, it's really a patient-specific total hip replacement. And what I mean by that, because we rely on preoperative data. We have to get a CT scan of your legs. We know exactly what your leg lengths are. We know exactly where your pelvis is in space. We know exactly how big your cup is. We know exactly how big your ball is. We're able to be a little more accurate on making sure the components that we're putting into you match your anatomy. And we do that by basically virtual preoperative and intraoperative planning. As you can see on the guide on this screen over here on the right, this is a plan that basically we get every time we're planning a surgery with the Mako. Is we know we're going to put the cup, we know how we're going to recreate this particular patient's anatomy, so that when we're done, we're recreating the center of that hip. Their muscles and tendons that are used to being in that position are replaced there, and that allows us to be able to have a more well-functioning hip. And we'll talk about why those things are important. The other thing is how consistent we can be. I think high-volume surgeons like myself that do a lot of hip replacements do a really good job of hitting our targets, putting our cups where we want to, putting our stems where we want to, putting the combination of those two things together so your hip's going to last a long time and feel as normal as possible. However, no matter how great a surgeon you are, we cannot be as accurate as the robot allows us to be. And the things we're trying to avoid in patients, because once again, we do a good job with hip replacement. We want to minimize as much as we can the complications that can occur. Dislocation is a leading short-term complication from total hip replacements. National average is around 4%. So 4 people in 100 within the first year of their replacement will have a dislocation. Sometimes that's treated non-operatively, sometimes you have to have surgery. It's also not cheap if that happens. You know, that kind of surgery costs about $42,000 on average. So if you can avoid that complication, you're going to save yourself a lot of misery. The most common long-term failure is implant loosening caused by vertical cups and polyethylene wear. So what does that mean? Well, vertical cup means the surgeon put your cup in at an angle that didn't necessarily match your anatomy very well, or when it was put in may have matched your anatomy, but your anatomy may have been abnormal and not realized. So there are definite targets that we know based on our research and based on clinical data that we want to hit. And if we can do that, we know that we can decrease wear. The other complications, leg length discrepancy. So you know, your patient comes in and their one leg's 2 inches longer than the other or shorter than the other. Leg length discrepancy is the leading lawsuit following total hip arthroplasty in the United States. And the reason it is because it's very common. When we replace a hip, we have to do 2 things. We have to recreate not only how long your hip is, but how far the hip is away from your body. So we call this leg length, and we call this offset. So you can imagine, if we know the target we're trying to get to, it's much easier to recreate that. So if we put it out here, your leg length is fine, but your offset's too much, it's going to cause a lot of pain on the outside of your hip joint. It's going to cause some other functional problems with your gait. If your hip's too short, your muscles are going to be too short. You have increased chance of dislocating. Your hip's too long, it's going to be more painful. You're going to have that leg length inequality, put a little more stress on your back. So the recreation of length or leg length and offset is very important at preventing dislocation and preventing malpositioned implants. So this is some things that we talk about with acetabular cup orientation. So when we put an acetabular cup in, we want to put it in at about 40 degrees of what we call inclination. So if you go to the floor, you go up about 40 degrees. That's where we aim for. We use rudimentary things in the operating room with standard techniques to achieve that. We also want the cup anteverted, or going to the front, at about 20 to 25 degrees. And once again, we use things in the operating room without the robotic system that allows us to achieve that. So if you put your acetabulum in the wrong position, you can increase your dislocation, you can affect the leg length like we talked about, we can alter how you're walking, we can have component impingement. So if you put the cup too rotated, when you flex your hip up, it can hit the stem can hit the ball, the stem can hit the socket. And if you have it in the wrong position, you can increase your wear rates, which can increase what's called osteolysis, which is basically the bone being disintegrated by your own body as it's attacking the breakdown products of the polyethylene. And it can lead to long-term revisions where you take something nice and pretty like that and have to do huge surgeries in order to get things recreated to the point which you hopefully would have had done the first time. So, you know, sometimes data will make surgeons realize that maybe we're not as good as we think we are. A recent paper from Mass General showed that among their surgeons, we're talking about world experts in hip replacement surgery, you know, founders, fathers in hip replacement surgery around the world, they only hit their target in their desired zone 37% of the time. And that's kind of, it's a statistic to me that says, well, you know, is that bad? Well, yeah, I mean, it's not where you want to be. Now, does it have long-term outcomes? Studies show it does if you get way beyond. But if I want to hit this target, I can accept being off a little bit. But if I'm off a lot of bit, it's going to have long-term consequences. So how do we put the cup in? How do we put the acetabulum into the patient? Well, typically patients are laying it on their side or on their back. We have, with manual techniques, we have to make sure you're positioned properly. If you move during the surgery, it can affect positioning. We have to have something to visualize angles based on the floor, the ceiling, the corner, and the wall. However, there's no real good method to consistently and accurately determine a patient-specific plan while that patient's moving, because we don't have the CT scan, we don't have the information with the preoperative planning that allows us to do that. And once again, the component position is based on the surgeon's ability to estimate where that patient's pelvis really is in space. Now we do have navigation systems which do a pretty good job at telling us where your hip is in space. The problem with it, when you know where the hip is one thing, but when you're actually reaming that acetabulum and putting that cup in, that's another. And that's what the robotic assistance allows us to do a lot more accurately. So while we're actually reaming that acetabulum, the robot knows exactly where your pelvis is in space. We're able to ream just the amount of bone we have to in the proper alignment and orientation so that we only take away the proper amount of bone. And that allows us to put the cup in the right position. And the way we do that, once again, is we have the preoperative 3D CT scan to do that. The other thing that allows us to do is it allows us to make our neck cut with robotic assistance and guidance. We know where we need to make the neck cut based on the patient's CT scan, and we can actually use the instrumentation to show us where exactly to make that cut in order to recreate that leg length and offset. And you know, our goal is this: trying to get our cup inclination, how much it is from the floor, inversion within 5 degrees of the plan, and the cup center of rotation, where we want your hip rotating around, within 2 millimeters. And those are very, very, very narrow targets to try to hit manually and be consistent, just as that study we talked about showed. So this shows you kind of what we do during the surgery. So you can see here, here's our reamer on a drill, pneumatic drill. And we basically bring the reamer into the operative field, and it will lock into place exactly where we need to ream. And instead of reaming multiple sizes like we have to do in standard hip arthroplasty, we start with the final size, go one time, and we're done. So it also decreases the trauma to the soft tissues going in and out with instrumentation. And then when we place our cup, the cup is held in a static position, and when we're hitting it in, it doesn't move from where you're planning. So if the patient moves, if you move, it stays in one position. So it ensures the cup gets positioned more accurately. In the lab, which obviously systems like this have been studied very extensively in the lab, but also in real life, all errors were less than 3 degrees with anaversion and with inclination. 100% were less than 3 degrees. This was 4.8 times more accurate than conventional methods with anaversion, and 4.2 times more accurate than conventional. In the manual patients, while 100% of the errors were within 3 degrees with the robot, 16% were within 3 degrees with manual techniques. So that's a pretty huge difference. So you can see if we're really trying to hit a target more accurately, we can't do it without the use of the technology the robot offers us. So with all that being said, what are the real benefits? What are the patient benefits, the patient value for having their hip done with the robotic assistance? Well, like we talked about, reducing your length discrepancy, decreasing your risk of dislocation, improving the soft tissue tension of the hip so your hip feels more like your own hip, improving your postoperative range of motion so once again your hip feels more like your own hip, doing what we can to improve the survivorship of the implant, and if your hip is placed in the proper position, you typically will have more rapid pain relief and return to daily activities. So as far as the talk goes, that's pretty much it. I hope that you all now understand what normal anatomy of the hip is, and understand what arthritis is and the treatment options for hip arthritis. I hope now that you understand what a hip replacement actually means and some of the basic things with the robotic system. So at this time, I'm going to go ahead and open it up to question and answers. But before we do that, I want to kind of show you what happens in the operating room. So in the operating room, we have this nice panel here, and there's one of the folks with Mako that runs this, and they're able to basically change the plan or show me things based on what our preoperative plan is. And this little $1 million baby is the actual robotic arm, and it allows me to place it in a position during the operating room that locks in. There would be a reamer on the end of this that allows me to place your hip in a perfect position with your cup based on all of our preoperative planning. So the robotic part of it is this machine here. We also use this for knee replacements. This one here actually has been busy today. We did two partial knee replacements before we came in. So that's all I've got. I'm opening up now for questions. Ed.
Dr. Ponder, what relationship to that robotic gizmo in the patient lying head to...
Yeah, so like you would have a patient lying down, and on the patient we put arrays, so basically reflectors that allow this camera, which is essentially a GPS, to know where the patient is in space. On the robot, there's also mounted a mirror, so it knows where it is in space. So the patient's lying here. The robot can be moved in and out of the field, and when it's time to do the reaming on an acetabulum, we bring the robot in this position. So if the head was here, the feet are here, the back side's here in front of me with the patient on their side, I'm able to bring that in to ream their acetabulum.
And that's how you do it? You're holding on to that thing?
Well, there's actually a different end for the hip. This is the end for the knee, and we literally finished about 20 minutes before we started here, so we didn't have time to change it out. So it looks a little bit different, but yeah, this particular arm, we control it this way. And it's got 6 different degrees of freedom and motion in there to get me exactly where we need to be.
And you're monitoring the screen while you're doing that?
Exactly. So when we're actually reaming, Ryan, is there a way to? We'll probably not be able to do the reaming view. When we're actually reaming the acetabulum, it's giving us real-time data. This is where you are. This is where you want to be. Move your hand up. Move your hand down. Locked into place. Pull the trigger. Stop.
You can't get to it because we have the mapper.
Right.
But I can show you how this moves around.
Okay. So he's going to show basically how we can plan this magenta line here, which a lot of you guys may not be able to see in the back of the room. This magenta line here represents the bone, and we can plan the placement of your cup both 2-dimensionally and 3-dimensionally based on you. So that's basically what this is representing.
Thanks.
Ma'am, you're welcome, Ed. Did I answer your question?
Yes.
Okay. Thanks, everybody.
Thank you.